Set apart in the far northwest corner of America, Seattle has garnered the reputation as a laboratory for innovation. The Puget Sound area is home to leading companies in many different industries. Boeing, Microsoft, Nordstrom, Costco, Starbucks, and Amazon.com come quickly to mind as enterprises whose products and services extend to a global market. Established in 1861, the University of Washington became home to one of the most progressive medical schools in the nation. It was at the university's teaching hospital, Harborview Medical Center, where some of the most profound changes in orthopedic medicine and trauma care were introduced during the 1970s. This represented dramatic change in the care of patients who were literally dying from their injuries, in most cases before they ever reached a hospital. Spearheading this change was a physician, teacher, mentor, and visionary named Kay Clawson. Dr. Clawson knew change was needed to save patients' limbs and lives, and he set the stage with what now must be seen in historical context as a bold and remarkable master plan. His vision of immediate surgical stabilization of the severe skeletal injuries, coupled with rapid transport from Medic 1 and aggressive resuscitation in the emergency room, would prove to increase survival and enhance recovery for these multiply injured patients.
Well, everything is incremental, and it started really way back for me in the 50s when I was a resident in San Francisco at Stanford and San Francisco City County Hospital, where we had a large number of hip fractures coming in. And we were taking care of them, getting them put together so that you could operate on them, and using a flanged nail, sharp nail that you could pound in to put the bones together, sometimes a plate, screws, things of that nature. And the results, to me, were not good. We were losing a lot of patients.
He was a real icon, as far as I'm concerned, of orthopedic surgery, and particularly academic orthopedic surgery, because he was all about trying to solve problems for the patient.
You had some visionary people who were willing to take a chance. So Kay Clawson, I think, falls into that category, a visionary individual who was willing to take a chance.
Dr. Clawson found other physicians who were disillusioned with the standard approach to treating hip fractures, including Mr. Ian McKenzie, who Clawson met while working in London.
He had devised a screw, a self-tapping screw that he could put in, and then he put a sleeve over it and a plate on so that it would slide and collapse and let the bones come tight together. With the typical British way of doing things, he said, they will never allow me to use this. This won't be part of the healthcare system. So if you can use it in America, here, take it.
Clawson modified the self-tapping hip screw and came up with a blunt-nose device that he felt could greatly improve and standardize the fixation of hip fractures.
And the beauty of it was not only did we have a technique that you could do exactly the same way, but we could stand the patient up the next day, have them put weight on it, impact it, get it secure, and implement an early treatment program.
Then, turning his attention to femur fractures, he was fortunate to meet a Professor Bühler in Austria, who had adopted a technique developed by Dr. Clincher in Germany.
So they could nail the femur fractures with the clincher technique, which was to make a little tiny incision in the hip and go in and poke a hole and ream it out with a big reamer and put a huge nail down that made it very, very stable. And they would do that very shortly after they came to the trauma hospital.
Intramedullary is inside the bone, so when you look at a bone, it's pretty hollow in the center. And so we found that with very small incisions that we could put a metal rod, almost like rebar, down the middle of a bone and fix it without exposing the whole fractures. So you wanted to be able to fix the patient and mobilize them, but you couldn't do big surgery, blood loss and infections and all those things. And so with small incisions and with an X-ray fluoro machine that was new then, we were able to see what we were doing and be able to fix these through very small incisions and get people up and get them going again. So it was very exciting. Still is exciting.
We were working towards the goal of getting patients cared for by trauma surgeons, people that would devote themselves to a technique, and when a patient came in, would be available to care for them definitively right away. That was our goal. It is not easy to do because it takes a dedicated staff. It takes people that are willing to devote their lives to this type of surgery. And we were working in that direction. But that's another leg of the story, because that did not happen and probably wouldn't have happened if it hadn't been, again, for a young resident by the name of Sigvard T. Hanson, who was a resident at the time that we started this, taking a full-time position at Harborview immediately on finishing his training, and liked the technique, embraced the concepts, and as a full-time orthopedist at Harborview, he was there all the time.
The thing that was interesting, or that got me interested in the trauma, was that I found out that I had a natural sort of ability to do three-dimensional things. So even as an intern, I would go down and do the hip fractures while they made the residents go to the clinic.
Ted Hanson is a farm boy from Eastern Washington. Incredible three-dimensional ability, and just very strong in his convictions.
The thing that we did that was actually more important than any of those things was that we realized that you needed to fix open fractures, more even than closed fractures. My rationale was that a fracture that was severe enough and displaced enough to cause the skin and the muscles to break down or be injured, that they needed more support. So we should immediately fix the skeleton. Well, before we did that, the idea was that that was too risky, because you're putting a foreign body inside these soft tissues, and infection will be a problem. But I thought it would be less if we fixed the skeleton, because then the soft tissues are back to their normal length and their normal shape, and the circulation is improved, and so it should be more resistant to infection.
There was something else happening at the same time, and that was a Swiss group that had visited here with me, devised a whole new system called the AYO System, the Swiss AYO System, of fixing fractures with different size, different types of screws, plates, a whole system of care.
But while Hanson's convictions told him he was doing the right thing for patients, the orthopedic community as a whole, and especially in the eastern United States, were not so enthusiastic about these approaches.
They weren't accepted at all. They would come to our conferences and stand up and shout that we were doing malpractice, and most cases we did were considered malpractice then, which was a little difficult. I was, pretty new, and I thought I was doing some really great work, and to have people say that we're very respectable people that I was doing malpractice, that was a little hard to face, because we were doing some things that were quite a bit different than what other people were doing.
I was having trouble getting papers published, this type of thing, early on, because it was such a departure. The community resisted it.
Dr. Clawson made me the chief of the trauma service. But the point was that the reason it could be done is because with his prestige as a chairman and having been around, he backed it up and kept people from stopping us, because there were people in town that wanted us to stop doing that. But a lot of people really will not do anything that they can't find a quote in the literature that says this is okay.
So resistance to change in some cases is seen as resistance to improvement.
That's of course it's true, isn't it? If you can't change, you can't improve.
It was just this concept of doing all things in one hospital one way that didn't happen in America. That's not the way we were set up to do things. And we took our lead from Britain, where they thought everything could be treated in plaster casts and in traction.
But plaster casts and traction were not to be the future of orthopedic trauma care.
I wasn't thinking about the future. I was working 18 hours a day. The future was a little sleep at night, and so at that time we were taking care of a lot of people, and recognized that we were doing some great work, because I knew how well the patients were doing, but wasn't looking at the future quite at that time. We learned a little later that it was pretty great, and a lot of people accepted it.
Now, you have to understand that this came at a time when everyone used the word conservative management of fractures to refer to non-operative management. So you have to decide for yourself, is it more conservative if you had a fracture like this to lie in bed for a long period of time, or to be in a cast from literally your nipples to your ankles? Or would you rather have an operation that would enable you to be up and out of bed the next day walking around?
It changed so quickly here because Clawson had the vision and Hanson was brave enough and good enough. He was so good that he could do this and it would work out well, whereas other people might stumble with it more. So I think between the two of those, that's what sort of set it off.
That's correct. It's exactly what it demanded. Sicker and sicker patients were able to survive their acute injury to make it to the hospital. And as you say, with those injuries, it required a well-developed system of working the patient up. And, you know, parochially, what was nice was the general surgeon was always recognized as the captain of the ship.
What this started was the concept of a trauma center. And as you know, Harborview Medical Center is one of the first, and I would argue still the best trauma center in the United States and perhaps in the world. It's what we call a level 1 trauma center, which means that that's where the really bad stuff goes. And now it exists as a resource for much of the country.
Medic 1 originated in Seattle and 911 originated in Seattle. Leonard Cobb was first, and then Mike Kopis did most of the work. And all of a sudden, we had to face problems we had never seen before, because these were people that were all dying at the injury site. And now they're alive and they're coming in, and the injuries were just much greater. And it wasn't single injuries, it was multiple injuries.
And it was the first city in the country that developed this fire department-based, pre-hospital trained personnel that would respond to the injury, initiate care, and deliver to a single center that's dedicated to trauma.
But a majority of the concept of putting people back together are people who come off a farm, out of a major automobile accident, 25-year-old mother of 3. It's people who are your neighbors, who inadvertently get injured unexpectedly.
Right. As is often said, trauma is the great equalizer. At the moment the SUV hits you in a crosswalk, it doesn't matter if you're the poorest or the wealthiest person in the world, you're hurt, and you need to go someplace where they know how to do it. What is really important is that the patients have access to that kind of facility.
Because trauma patients don't have a lobby. Nobody thinks they're ever going to be a trauma patient. You're never planning on being in Harborview's emergency room at midnight on Saturday.
I give this sort of standard lecture on ICU care around the world now, literally, and we're always trying to identify things that we've done that have had a major impact on outcome for the injured patient in the ICU. And I always give credit at the end to probably the one thing that we truly can identify that had a major impact on survival after severe injury was the change in orthopedic care.
When I did my trauma fellowship, there were really only 2 trauma fellowships in the country. I had a sense of great optimism for the institution. You could sense there that there was a history and a community of innovation.
I'm most proud of all the people that have trained here. That I've got people in almost every country around the world. If I go in a faculty, it can be in Hong Kong or Singapore or Australia or New Zealand, or the major people there will be people that train at Harborview.
Well, it's in many ways our crown jewel. It's the thing that defines our department and our training program.
It's a classic Seattle story. One wonders if it would have happened anywhere else.